Welcome everyone to our, I think, first of a two-part seminar called Looking After Your Vagina, a discussion about dilators. And we were supposed to have 3 speakers at this point. We have someone who was ill, so we'll start with Dr. Birdsall introducing herself, and then Dr. Nurkic, and then I will talk about Dr. Tejada Burgess. If you do have your video on, please turn it off and also mute yourself. Thank you. Mary?
Great. Hi, well, welcome. My name's Mary Birdsall, and I was a gynecologist. I'm now retired, but I'm speaking today really about being an anal cancer survivor. So I was a busy New Zealand gynecologist running a large multinational IVF unit when I developed anal cancer. And so today I'm going to talk really about the patient experience, how it was for me, and more importantly, how I think it should have been. And so that's the expertise that I bring to the party today. Thank you. And now Irina.
Irina?
Hello, good morning from Perth. Thank you for inviting me again. I'm a specialist continuous women's health physiotherapist here in Australia. It's a physiotherapy area that requires additional postgraduate training. So I've done my master's and then 2-year specialist training as well. I work here with patients with any pelvic health issues, and I do get patients referred following the pelvic radiotherapy. That's not just my cohort, but I do have experience in seeing patients following anal cancer and pelvic radiotherapy. Thank you.
Okay, I forgot to introduce myself. I'm Mary Jo Murphy, and I'm a anal cancer survivor, nurse, and patient advocate. And I'm on the board of IANS, the International Anal Neoplasia Society, who's putting this on. So we're very disappointed that Dr. Trevor Tejada Burgess was ill today, but we're going to go forward anyway. And I'm hoping we can, I know this topic is going to be interesting and we probably can't cover it all. So we're going to ask him to come back and we'll do a part 2, but he's a clinical associate professor in gynecology and oncology group at Chris O'Brien Lighthouse as a senior staff specialist in 2013. And prior to that, he worked as an attending physician at the program in women's oncology at Women's and Infants Hospital, Brown University, where he completed both a gynecology oncology fellowship and subsequent breast care fellowship. Just to move ahead a little bit so we don't spend a lot of time on this. The reason that he was asked to do this is that he does a lot of counseling with patients pre, during, and post radiation about dilator use. So I think that'll be something to look forward to for our next seminar on this, which will probably happen in 2 or 3 months. Okay, next slide. Housekeeping items, please turn off your video and stay muted, because if you're not muted, we can hear everybody talking and dogs and things in the background. If you want to ask a question, I suggest you put it in the chat at some point. We may just open up the mics depending on how much time we have. But feel free to send a message through chat as we're going on, and we will do our best to answer everything. Okay, next slide. This is in memory of Deborah Young, July 30th, 1953 to May 21st, 2024. It's important for us to remember why we're here, and losing Deborah is one of the reasons why we focus on these things, this disease, and picking it up earlier and getting better treatment. Next slide. And as usual, this is not intended as a form of medical or healthcare advice. It's not a substitute for professional diagnosis or treatment. And always, if you have questions, seek guidance from your medical health care providers. Okay, we can get started.
Rachel, will I kick off? So,
Yes.
hi again. My name's Mary, and 2.5 years ago, I was diagnosed with anal cancer. And at that stage, I was a working gynecologist. I had stage 2 disease and was treated with the standard chemo and radiation. I don't remember anyone talking to me about my vagina prior to treatment or during treatment. And I wondered if they thought that I would just know things, which of course I didn't. I was terrified about getting a stenosed vagina. I'd seen women, treated women with stenosed vaginas, and I just thought that would be such a terrible outcome. So I went off and got myself some vaginal estrogen cream and used that twice weekly throughout my treatment. I never checked in with anyone with that. I just thought it inherently made a lot of sense because I knew how much vaginas loved estrogen. And I think it just meant that if there were any adhesions developing, just by putting in the cream might have kept things better. I'm not sure. When I had my last session of radiation, which was 2 days prior to Christmas, at that stage I was given a pack of vaginal dilators. They were pink, with the advice that I'd know how to use those. I think they thought because I was a gynecologist. And I remember thinking, with a completely raw perineum and butt and with really savage diarrhea and terrible pain, it didn't seem that that was the optimal approach. But I was also never offered pelvic floor physio, and arranged that myself about 6 months later and found it incredibly useful. So I guess from a patient perspective, what I wanted was someone to care about me as a woman, to not just think about my cancer. I wanted to know that I wasn't going to be irreversibly damaged and that I was angry that that didn't happen. This wasn't just about my cancer. This was about, I wanted to be looked after as a woman, and I wanted to be looked after as a woman with a future. So I think that this area could be done way, way better. And my experience absolutely is not going to be everybody's experience. But I guess my experience made me want to be part of an advocacy group where we can work better to help our healthcare providers look after us way, way better. And I think looking after our vaginas is about making sure that we have a future. We are going to be able to be women afterwards, and that we are going to be able to have smears and have a future. So that's why I was very keen to make this a subject for us. And so thank you for joining us to discuss this really important issue. So having said what it was like as a patient, I'd really like to hear from Irina about what the approach is, what pelvic physiotherapists can offer us.
Thank you, Mary. That's really nice that you share your experience. And I think this is one of the key things we need to do for future. We have to go and listen to our patients, and we need more research where patients are involved and we're listening and hearing about the experiences so that we know how to better tailor the whole management. And like you say, I like that you said you wanted to be seen as a woman with future rather than just somebody's looking after managing your cancer. So that's really powerful the way you said it. Sorry, I'm just talking and trying to get going. So my name is Irina, as I said. I wanted to stress that in your part of the world, wherever you are, if you need to see anybody for pelvic health issues in terms of physiotherapy, please look for someone who's done some additional training, because not our usual physiotherapy undergraduate training does not equip physiotherapists for this type of physiotherapy. So we go under different names in different parts of the world. Even in Australia, we have continence, women's health, we've got pelvic health, pelvic floor physiotherapists. So please find someone like Mary did. And we're hoping that the medical teams are better at incorporating this in the interdisciplinary management. So I just want to put a little bit of disclaimer, even though we're talking about a woman, meaning a cis woman, we're talking basically about any person with vagina that might have gone under the pelvic radiation therapy, and we're going to talk for cancer, and we're looking for vaginal dilator therapy. So again, some of you, most of you, I would assume already know what vaginal dilators are, but I wanted to also draw attention that there's so many differences in vaginal dilators. They're sometimes called inserts, accommodators, trainers. You'll hear me probably say trainer. And this comes from the fact that language is very powerful. And when the name dilator or dilation implies that it's just kind of going to go in and dilate, and that could be a little bit scary for some patients or a little bit threatening. And it's used in other conditions such as vaginismus, dyspareunia, so pain or difficulties with intercourse and post-surgical interventions and so on. So for that reason, you might come across these other names. They come in different materials, as you know, and there are different graduations. So some of them have like 8 in a set with gradual sort of increase in length or girth, and some of them might be 4. And shapes are different. Again, some are curved, some may have more narrowed, and some are blunt. There's handle or no handle, and cost is also different. So why do we use these dilators in someone following pelvic radiation therapy? The rationale is to try to prevent that narrowing and shortening, but ultimately we want to allow the woman to be able to return to sexual functioning and preserve the patency of the vagina for vaginal examinations as well. So if we look at evidence behind it, is there evidence to say, yes, from research we can see this is definitely something we should be doing? Well, it comes from our observational studies, which, but it is promising, saying that those women who have used the dilation after radiotherapy have less stenosis. But it is still unclear who are the women who will respond better, who are the women that will not, and how we deal with and how we help them. So we do need better quality randomized trials. Unfortunately, they just haven't been done. So we're hoping it will come. And the Cochrane review, which looks at all the research that's been done, looked at and came up with a statement that dilation months or years after radiotherapy might help restore vaginal length. I wanted also just to spend a minute on explaining that in the pelvic floor, we do have some active and passive structures. So we do have muscles, pelvic floor muscles, that are voluntary sort of muscles that we can contract and relax, and they are more active structures. So we can retrain, and we can teach them to lengthen and relax a little bit better. That involves our sphincters as well and the whole pelvic floor. But we also have passive structures, which are made of connective tissues. And you've probably all heard about collagen, elastin. There's many other components to connective tissue. The connective tissue, for example, makes our ligaments and tendons, and also those membranes that envelope the organs inside the pelvis, and also they make the bit of a framework and structure for the vaginal walls. And you can see even on this picture here, the small bundles of the muscle fibers are enveloped and surrounded by connective tissue and these passive structures. And these are structures that tend to, can be sort of stretched, but also tend to become more fibrotic or scarred, as well as the muscle fibers, but particularly these connective tissue fibers following the radiotherapy. So just a little revision on pelvic floor muscles. They are muscles that stretch from the pubic bone at the front to the tailbone at the back. They have 2 layers. There's a deeper layer and a more outer layer with the sphincter and the entry to the vagina small muscles. You can see a yellow is the nerve. And the function in regards to what we deal here and what we're talking about in terms of vaginal dilators is that we're trying to allow the return to sexual intercourse for women who want to. And for that, the pelvic floor and the soft tissues need to be able to accommodate something of the size of an erect penis for the intercourse. Nervous system I'm mentioning here because it's all perceived, and the information from that area is picked up and perceived and interpreted in our brain. So it is playing a big role in how we feel about this area and how worried or threatened some pressure or touch or maybe. So it's an important part of the experience, even with vaginal dilator therapy. And we know from research and from that following radiotherapy, there will be increased tone. So what I'm talking about, if you ever have tight muscles in your like coat hanger muscles, as I call them, you know that's the increased tone. You're not deliberately holding, but they've gone a bit shorter and tighter, and they lose their length and flexibility and ability to contract and fully relax. And that's what we can see following the radiotherapy and pelvic floor muscles, it can be present. And the problem with that is that if you lose, because these are the muscles that surround an entry to vagina, if you shorten them, they start to obliterate and become unhappy when you have to open and stretch them. So I am going into a little bit of an ideal scenario, because I have to say this is not happening with all of my patients, but I'm talking that before radiotherapy, there should be a prehab physiotherapy. And we spoke about this in our previous seminar where Dr. Holliday was also involved, and in her center does this really well. With this, I would really ideally like to see you as a patient and identify through our talk, is there anything in terms of your bladder, bowel, prolapse, or pain that currently is an issue before radiation therapy, and how can I help to optimize it before it starts? But it also gives me understanding what happened before, what's there before radiotherapy. We also talk about sexual function and any issues that might be pre-existing, like pain or difficulties already. And if there aren't any, I want to understand also what are your expectations in terms of returning to sexual activity, and what have you been told previously. I want to also talk to you to understand you, like your lifestyle, how well do you sleep, what activities, exercise you're doing, work, hobbies, your social life, because that every person is different, and these things matter in your recovery. So we want to optimize them as well, but also how you're coping, how supported do you feel? Do you need some more information to be provided? Is everything making sense to you? Because sometimes you might feel there's a lot of information, but you can't process it. And this is a good opportunity to probably go through all of that. I'd like to then go into explaining following radiotherapy what the issues will be. And this is where we explain the vaginal health and changes that will occur and their impact on sexual function. And we introduce vaginal dilators and explain, and there's opportunity to touch and see different models of the vaginal dilators. My recommendation is never to give out vaginal dilators with instructions only. I found, let alone just to tell a woman, go and find or buy dilators or buy a dildo, which doesn't happen so much with radiation oncology teams, but I've just had a plastics team, for example, who did a surgery, told a patient, just go and buy a dildo, which is really not on. We should be beyond that. I would like to, with consent, to do vaginal examination on a patient before radiation therapy, so that I understand and the patient understand what the pelvic floor muscles are and how they feel when they contract, when they relax. I'm not a doctor in a sense that I'm not a medical doctor, that I can actually diagnose mucosal issues, but I have enough experience that I can escalate to the doctors, and if there are any issues of concern in terms of maybe there's a bit of inflammation, maybe there's a thrush that hasn't been detected or anything like that. But by the time you have come to see me, the doctors would have looked and addressed all of that. So we're working maybe on any identified issues pre-radiotherapy as well, bladder, bowel, and we do use vaginal trainer in that session. So you get an experience of what does it feel where the larger size dilator can go in, and how does it feel even to gently grip and ungrip around it, particularly that ability to let go around the dilator is really important. And I would then set up a program for you, which would involve mostly that awareness of pelvic floor, unless we have to up-train or do something more with your pelvic floor. But mostly if we found that there are TENS, then there would be a relaxation program. We would discuss sexual activity in vaginal trainers treatment, and definitely we want to know that you are keeping active, because we know there's a strong evidence for with cancer survivors and people battling cancer to be active and keep up with general exercise. And it's an opportunity for questions and providing more information. So during radiation therapy, I step back, I'm not involved, but I'm just wanting to reinforce that it's important to follow the advice of the radiation oncology team. And I know they all go through advice on diet, skincare, making sure you sleep well, and how to manage your fatigue and activity. And it's really important to escalate issues with your team. Talk to your nurses, talk to your doctors there. We don't recommend vaginal dilator therapy during radiation treatment, and I'm curious to hear if any of you as patients maybe have tried it, but I think it's, my understanding, it's very acutely inflamed and raw, and it's not to be done. And the consensus statement is not to be used. It might be even it might be actually giving much worse results if you do it at that stage. And it's fine at that stage to be aware and tighten and relax your pelvic floor muscles, possibly a little bit for that vascularization and recovery as well. So following radiotherapy, I'd like to see you. And you'll hear that the consensus statement from experts says probably it's okay to start at 4 weeks. So I've put 4 to 6 weeks. Some experts say 6 weeks. So I think if you've come at 4 weeks and you're on inspection, your mucosa does not look quite right, we might sort of wait for a little bit, or we might consult your doctor to sort of see for their opinion. Again, we would talk. So I want to know, where are you at that point, and what's going on, and how you're coping, and what are your goals and expectations, because it's not on me to enforce that you must do this if you're not ready or you can't do it. However, it's really important for us to inform patients at this stage that there is probably better window of opportunity to act early and do some of this vaginal therapy early on, rather than leave it and then trying to catch up and deal with some more fibrosis once it sets in, and scarring once it's there. Examination, again, with consent and with care. My sort of way to approach it is that I want to keep your pain and your overall bother, apprehension, anxiety, anything that bothers you about this examination to low or medium. So I usually give you a scale of 10, and I say if it's hitting 4 or 5, we stop, we see if we can modify. There is a way to get slowly around it, but we don't push through pain or go over your anxiety with this. We might do some treatment if it's allowed at that time, and vaginal dilator treatment, like I said, if it's appropriate. So we give you choice, consent, permission to stop and to change what we're doing during that session. We want you to say stop as per these guidelines, rather than just push through, because that's not helpful. And you need to, you are always informed with whatever I'm doing with this examination, as well with vaginal dilators. If I'm going to move it, I would say, I'm going to move it, I'm going to press to the right, so there's no surprises and reactions. Oh, sorry. And there are women who, following radiotherapy, opt to manage independently. And if they feel that they can do it with that prehab that was done, and they feel that they're going well, and they might even early return to sexual intercourse, only they could return to physiotherapy only if required. So please, I want to stress that it's not a must, but look, ideally, maybe it'll be good to just tick off and even phone call with the physiotherapist to say, go through the screen list and a checklist and say, yes, this is all going well, and that's it. This is just a slide that looks at evidence. So when do we start? Well, like I said, Cochrane review said that there might be even possible harm and no benefits if we do it during radiotherapy. And this consensus statement from 2014 also says 4 weeks after radiation therapy. There's no single approach. We don't know for how long to use it. But again, the expert opinion is 2 to 3 times a week for 1 to 3 minutes up to 12 months. And what all agree is that there's poor adherence, psychological distress, ambiguity in instructions. And that's something, again, like we have to do better. So with that vaginal examination following radiotherapy, what I'm taking out of that is how sensitive is the vagina now, is there much resistance to that insertion of the vaginal dilator? And what do I think is that the patient is guarding, and I can coach her through and say, let go, and we get a little bit more in? Or is it that there is passive, that connective tissue that has started to maybe become a little bit more shortened and needs a little bit more of a work with passive dilation and stretch? Or is there anxiety, and how much is that contributing? It is a normal degree, and I'm happy to hear from you as patients. Did you feel a little bit apprehensive and worried when you were doing it first time? So some of that is normal, but if it really overtakes everything else, we have to look after that along the way as well. So that helps with my clinical reasoning. What do I do? How do we approach it? And also I teach you as my patient, because when you go home and you do this, I want you to keep in mind all of these 3 things that you have to reflect on. So resistance to insertion, how apprehensive are you about it, and what's your pain like? And some patients do respond and say, it doesn't hurt, but I just don't like that stretch feeling. It feels like it's a bit bothersome. And again, we keep it low to moderate, not go through a lot of stretching sensation. So when I do it, I would always do it in a clinic before I instruct the patients to go. I consent. The patient can stop me at any time. All movements are announced, like I said, so no sudden movement with dilator. So the patient expects where it's going to move, it's going to press on this side or so on. Pre-insertion, we go through a little bit of relaxed breathing, because the abdominal pelvic cylinder with diaphragm on the top, pelvic floor on the bottom, and tummy muscles really are important and coordinated. So if you are bracing and holding your diaphragm and holding your breath and just breathing in your upper chest, it tends to actually squeeze the pelvic floor gently and hold, and it can contribute to more difficulty or more pain. So relaxed breathing, something we teach you even in prehab. General relaxation, so making sure you let go of your body parts, and a few other sort of therapies that we do depending on what we're finding. So there might be some external stretches for the legs that help a little bit to relax the pelvic floor as well. We place the dilator at the entry, and it's a few millimeters at a time, step by step. As we come with insertion, it's probably going fine to a certain point, and then we hit a challenging point, as I call it. So either it's the resistance, or might be that you're voicing this pain, and sometimes it's quite well coupled and matched. So when we hit resistance, you say, well, that stings a little bit now, or that's where I feel the pain. We want to keep that low, so we might pause here, and this is where we work on it. So I'm coaching you how to manage it. So we might work on the active relaxation of the pelvic floor. We might do even gentle grip, or clamp, unclamp, not to hurt yourself, but just gently to release more and let go. And we need to give time for soft tissue to lengthen, because soft tissue can really stretch. People do all sorts of weird things with their earlobes and lips and stretch their, but so I'm not talking about extreme, I'm just talking we need to give soft tissue time. It doesn't like to be quickly lengthened. And we might hold to release the area, and then advance a little bit more in until we hit next challenging point, and so on. Visualization also helps with some of this. It's for home program, it's the same principles as what I've just explained we're doing, but I'm empowering you as a patient to know, and so that you actually understand what's going on. With your hand holding the dilator, it tells your brain what's going on, but it's also your body part from vagina, you're getting information. So you're putting it all together and reassuring yourself and making sense of what you need to do. Where do I press? What do I do? It's very mindful, like I said. So it's not just you put the dilator in and you read a book. Should not be done in that context. And what size to start? So I would usually start you on if I've used, let's say, size 5, I might give you a 3 and a 4 to do at home, because I might already prepared with some manual therapy and then went for the larger one, but you might need to start with a smaller one that goes easy. And you do a little bit of that releases, and then take it out, and then you do one that's a bit more challenging, that maybe will only go halfway in, but that's where you're working on until you master it. And then we progress you, and we catch up periodically, so that I progress and you progress as well. It's initially done very static, so we might press and release, but eventually we might do a little bit of movement. So the aim is to also return you to intercourse. Again, like I'm stressing out this mindfulness approach and a little bit of clinical reasoning about what's going on. So I'm hoping this is useful to you as a patient, so you know what to look for. I've got an asterisk here where it says if you do have slight pain, because like I said, I don't want you to push through pain. You should never ever push through major resistance. Work on it. But if there is a slight pain, and we know that your skin, your mucosa, has been well estrogenized and it's healthy, there is the pain often does not necessarily mean harm. It's not that you're going to split or have harm the skin in there. Often it's the sensitive nerves that need to also be retrained, that now they're not tolerating that stretch as a kind of, well, that's a mild stretch. They're kicking in and wanting to protect you. So that's why there's pain. But like I said, we need to make sure the skin is healthy, mucosa, vaginal mucosa is healthy, and we are not doing harm. And from the dilators, I just want to finish with this slide, sort of saying that from rehab, we go to match play. So the whole point is like a returning an injured athlete to their sport. So returning to sexual intercourse for those women who want to return. For those who don't, we might settle on a maybe medium-sized vaginal dilator that is adequate for them to have vaginal examinations and tolerate a speculum or whatever they need to with examination. Again, with return to intercourse, it's a careful, graduated process. It's not all or nothing event. So I set the expectations for my patients right away, so they know there's no disappointments. It's a bit of a therapy as well. So careful sex initially. Arousal is really important, and we acknowledge that there might be physically impairments there because of the radiation therapy impacting on nerves, but also mentally. Lots is going on. So we know for women particularly, it's very hard to focus on the sexual activity. If you're not sleeping well, you're worried about many things going on in your life, and sometimes there's relationship issues as well. Lubricant is important. Even if you've never used it before, you will need it now, and we go through that. Control with a woman being in control with her partner during intercourse, and having a good communication is really important. And using that vaginal dilators before intercourse is also a must. It is a bit of a warm-up prior to penis going in. So rather than going from 0 to 100%, like what the penis size is, it's good to maybe use something in between as a sort of not a challenging dilator, but one that is kind of comfortable, larger size that's comfortable, and taking it out, and then it's a bit easier to go with penetration. So women should be in charge of position, penetration, and pace, and we go through some practicalities of this. And it might be just a partial penetration, initially stopping and troubleshooting and building up on this. So that's just a brief guideline on how maybe I would approach that return to intercourse. And I want to just stress with this slide that I am talking about a very narrow part of physiotherapy, vaginal dilator therapy. We do look at everything else, and we approach it very as through the individualized approach. It's you are in charge, and we're collaborating with you, listening to what you want, and it's also evidence-based approach. In other words, it has to be based on some science from research and guidance from there. Even when we lack it, we need to sort of have some of the justifications and rationales why we're doing something. It's not like, well, let's throw everything at you to see what works. There has to be some approach to this. Thank you. I did have one slide on but I don't think I had it in this presentation, showing you a little bit of the WA in Perth and Perth beaches, but I'm sorry, I don't think I've left it in this version of my PowerPoint, sorry.
Thank you. There's been some good questions, Irina and Mary, although I did want to have Mary say something. Mary is, as she said, she knows a lot about vaginas, so I want to know if you want to add something, or if you've seen any of the questions, and both of you, if you've seen any of the questions and want to add something before we open it up to people speaking or asking questions. And also realize that this is being recorded and that your names are there. So if you want to be anonymous, I think it might be too late.
Yeah,
I'm sorry, but that's... Yeah, go ahead.
I wanted to talk about a couple of things that came up in the questions. One was the question about dilators during radiation. And I think there is some new evidence, particularly coming out of the States that the use of a vaginal dilator during radiation only may lift the vaginal wall outside of the beams of radiation, and so may be useful in maintaining good vaginal integrity later. And so I think there's some exciting work being done in that area, and we should watch that space. I also wanted to bring up the value again of vaginal estrogen, and I don't think this is promoted enough. I think that postmenopausal vaginas, and we are all going to end up being postmenopausal usually after this treatment of radiation, then they shrink and they lose their ability to lubricate well, and vaginas lose their stretchability, which is a really important necessity for a vagina to cope with sexual intercourse and a speculum examination. So I think that even though radiation is going to damage our tissues, I think that the tissues will be all much, much better off with some vaginal estrogen. And vaginal estrogen usually comes with quite a scary applicator, and I don't think you need to use the scary applicator. I just think getting a little bit of vaginal estrogen, it's just a cream, putting it on your index finger and putting it into your vagina, and your vagina will just literally slurp it up, and it will be much better as a consequence for it. So I think that's really important. And the third thing that I wanted to bring up, which no one talks about, is when our ovaries are irradiated, even as older women, the testosterone production also falls through our boots. So the idea of having a libido after this is much more difficult, let alone the physical changes and the whole getting your head around having had a cancer caused by an STI is just incredibly challenging. So I think the use of a great physio is so important. And I think vaginal estrogen, we should all be on vaginal estrogen unless there's a good reason for that, like we've had an estrogen sensitive breast cancer, and also have a think about testosterone and reach out to doctors who are experts in sexual health, because I just think it's an area that is managed so badly in this area. Thank you.
That's great. We in the United States, I don't think we have a lot of sexual health experts, but there is somebody on the call who I'd like to have jump in. Amanda, if you want to say something, that would be wonderful.
Hi, thanks so much. Can you hear me
You
okay?
can turn your camera on if you want.
Sure. Hi.
Hi.
Such
Wait,
a lovely.
tell them who you are and a little bit of your background. I
Sure.
haven't met you, but I was introduced to you, so I'm glad you're here.
I'm so glad to be here, and it was such an amazing presentation, such great content. I am a pelvic health physical therapist here in the United States. I've been specializing for 16 years, and I have created tools and devices, specifically dilators and wands, to help address pelvic pain and sexual dysfunction, and have been focused really heavily on cancer in the last several years and helping to create awareness. And I think that it's always evolving and always changing. And the pelvic health physios in Australia and the UK and Canada are so progressive and amazing. So I think it's really lovely that it's an international crowd. There was a recent publication that came out that there was a particular radiation group that for the last several years had been placing the dilator during radiation. And what that was doing was, it was, as Mary had stated, blocking the front wall that was helping to preserve that tissue. So I think that now that that's been published and peer reviewed, hopefully that will be a different consideration that other physicians are abiding by to help protect that tissue for better outcomes for the vaginal tissue. And that's going to affect urinary health and bowel health, and of course, sexual health. So yeah. It's just something that has recently been published, but it was done for like the last 5 to 10 years.
Yeah, most of us, or a lot of us, were, especially those of us who had treatment a long time ago, this was not addressed. I know that some people were luckier. I think Helen Hutchings has, her experience has been better than a lot of ours, but many of us, no one paid any attention to it. And so that's why I think this is important. And the idea of perhaps is it too late to have things get better? I guess that's one of my questions.
Never too late. I would say tissue is so adaptable. And I know that it can feel like, even if it was years and years ago, it can feel like a big hill in front of you. I've seen patients progress, and it's little by little, a little becomes a lot. And so I recommend dilating most days. Certainly giving yourself grace to take a day off if life is busy or if you're not feeling well, but just even a little bit, and anywhere from 5 to 30 minutes to get what we want is like a low load, long duration hold to change the tissue. And just being really patient with yourself, utilizing a lot of lubrication and also body position changes. I think that's something that a lot of people don't know about. They think about laying on their back and placing the dilator, but you can lay on your side. A position that I love is laying on your back with your legs up on a couch or on a chair, so that you're in this kind of bent knee position and allowing your legs to really relax while you're like placing the dilator in. Allows your body to relax, to allow for better penetration with the dilator. And then another thing that a lot of people don't think about is there might be a day where you're able to place the whole dilator in, and then maybe on the next day life has been stressful, or you're not well hydrated, or you're experiencing changes in hormones and the dilator is not going in all the way, and that is okay. There are days that just happen like that, and your dilator session may be just placing 1/4 of an inch and just giving the tissue a little bit of break, but a little bit of experience with the dilator. And then you're going to come again the next day and it's going to be better.
Okay, thank you. One of the questions about the tears that happen at the opening of the vagina, it seems to me from what I hear and what I've experienced that people have different issues. Sometimes it's the webbing, sometimes it's scarring up higher, sometimes it's at the opening of the vagina. Can either all of you say something about that? And is there any way that you would use a dilator differently?
Yeah,
Sure.
I'll start, and I'll admit I'm not a doctor, and it's out of scope of practice in Australia for physiotherapists to change advice or do anything about medication. However, I do inform my patients and then move them on to go further discuss with their doctor. And I see there's a question about patients expressing concern about using estrogen therapy. We talk about a small local dosage of therapy, and this is what I tell my patients. So your doctor has prescribed it because we need to really improve the elasticity, the health of the vaginal tissue, and prevent these splits that are occurring now. And sometimes it's not just using, as the manufacturer has said, with the applicator, and some women push it really high up. They need to also apply it to that area. So I know Dr. McCloskey, who's also part of this group, often recommends like a pea-size amount, and they just also apply to those areas that split. In regards to their concern, if you're not a breast cancer survivor where your estrogen has been depleted and targeted, but even if you are, I think I say go talk to the doctor, because they will ask you to speak to your oncologist, and maybe you can have it for a certain amount of time. And there have been studies where they did the blood test and looked at the serum levels of the estrogen for women who have used the local estrogen, and found that it doesn't significantly rises, so it is safe. However, I can just give them information because they have heard about the dangers of HRT in general, and then hopefully encourage them. And the other role we play as a physio is checking, are they using it regularly? Sometimes women forget, oh, I've run out of the script, I have to go see the doctor, and immediately it can show with a bit more sensitivity, and it does impact the quality of the tissues there. So just keeping them on track with that estrogen is really important. And in WA, we have a menopause clinic where women can go, like Mary said. They often need also systemic HRT with testosterone being prescribed as well. So that's another sort of part of their care that will be included in the pathway. Thank you.
Mm-hmm. It seems to me that many of us many people have different experiences, and this is a topic that isn't always approached by our doctors. And anybody have any advice about advocating? I mean, for some of us, we are where we are, but for people that are just beginning or still are in a place where things can get better, any ideas about advocating? Because it doesn't seem as if this is something that, aside from women, anybody's paying very much attention to.
Look, I
Very-
think you need to, yeah, I think you need to advocate for yourself. And often going to see your family doctor is an excellent first start. The anal cancer is not estrogen sensitive, so you are not going to be at all compromising yourself or your survival by using vaginal estrogen. And even with, as Irina alluded, even if you have an estrogen sensitive tumor like a breast cancer, often physicians are pretty happy for you to have a little bit of this local estrogen because you get so little systemic absorption. It really is the magic sauce for giving whatever elasticity you can get back into that skin. It's absolutely better than anything else. And I'm sorry to promote it over vaginal moisturizers and other products that are done, but vaginal estrogen is actually the gold standard product. In terms of testosterone, look, testosterone in women is a vexed issue. I think that it's fair to say that there isn't a whole lot of research. There are a lot of products that have often been developed um, from male products, so you want to be really cautious about it. But I think a small amount, and it's often given in the form of a gel, can actually be really pretty useful just to boost up your libido. So it's certainly something worth considering, but I think you should do it with a menopause expert as opposed to someone who's not an expert in that area. I also wanted to give a shout out to older women because often I think I run quite a big Facebook group and a big support network throughout New Zealand and now Australia. And I think I hear from some older women who maybe aren't in a relationship and sort of say, oh, I don't need dilators or I don't need to worry about any of that. And I actually think that is not the right approach for those women, because once we've had this HPV related cancer, you want to be able to continue to have a decent vaginal examination. And so I think it's important, even if you think that you might not want to use your vagina from a sexual perspective going forwards. I think there are other important things about vaginas. So vaginas are really important to remain functional and good throughout our entire lives, and we just need to be respected as such.
I love it. Judy wanted to say wanted to have us discuss the psychological issues. I think that for people that were just handed a dilator during the treatment and said, use this with absolutely no instructions, there's a big loss in terms of your sexuality. But I'm just wondering if any of you want to talk about that, because I do think that many of us have had to just, because I think the doctors didn't realize that it was important to us to have a sexual life, because we were in our 60s, which is when a lot of women get this cancer. And so just anything you'd like to say about the psychological part of it, or anybody wants to say, feel
I'll
free.
just jump in again. Look, I think we
Yeah,
all need a
please.
psychologist.
No, go ahead.
We all need a psychologist in our corner. I love the fact that someone's described this treatment as an assault, because I felt it was an assault. I used to lie there on that radiation table, feeling like a lamb to the slaughter was what was going through my mind. Like, I know it was curing my cancer, but just what it was doing to the rest of me was really hard. And I would strongly advocate every single one of us who's going through this treatment to have a great psychologist and a great pelvic floor physio, because I think Irina's been a great psychologist in all her approach as well. So I think we need that.
Mhm, mhm.
Yeah, I'd just like to comment. Thanks, Mary. That's a great point. Psychologists are an important part. There is a lot of grieving through this process that patients go through. They're losing themselves as they used to know them, let alone sexual function. And often lots is happening in their lives as well. And so I do think we need to understand when that patient comes and sees us, where they're at and what's going on. I've got a patient that rocks up and says, dilators are horrific. I've tried them, and I feel that just handing out the dilators obviously did even more harm, because now I have to justify why I still want to use them as well. So it's really important that we do it right. But there is no one approach to every patient. And I'm reading in the comments, somebody has had great experience even during the radiation therapy and managed to use the dilators, where somebody could not do it for a long time. And I think that's the key message. Everybody is different. That's why I said it's very individualized. It's very much also what's going on in your mind, in your life, around you. And we have to understand that and pitch it, tailor our treatment so it suits you, and adjust it as you go through. So, yeah.
Amanda, in terms of the different types of dilators, can you say something about that?
Yeah, there are
I
different
know
types.
that you have a company that has dilators, and they looked very exotic compared to what I have. Lovely colors and shapes. But anyway, can you say something about, like, how would anybody even decide what to, if they were ordering it, what they would want?
I like to liken it to shampoo. Like, we all have different hair types and we all have different desires and needs from our shampoo, and dilators are very similar to shampoo. So there are plastic kinds, there are glass kinds, and then medical grade silicone kinds. From my perspective, when I created them, I wanted to make them, ultimately from 16 years of clinical experience, very soft and easy to insert and then remove, specifically thinking about radiation patients in mind, for when you're building up that new slough and your tissue is coming back and things are starting to regrow, so that the dilator is very gentle to that. And so I actually tapped into a lot of like color theory. So like, you use the word exotic, and I think that that's lovely. And I've never heard that stated about mine, but I wanted them to be cheerful. So I used different colors to invoke like a cheerfulness and to remove a medical stigma. If it were found, accidentally sitting out in a drawer or something, perhaps someone wouldn't know what it is, because it's just a really colorful tool, and it's not a skin color and it's not a medical color. It's just a pretty color. So I really wanted to evoke that. And I think along the lines of the psychology is like giving yourself grace and also tethering the tool to a goal. So, whether the goal is to have a pain-free medical exam, which we all have to continue to do throughout our life, especially if you've had cancer, or if it's to be with your partner again, or to have a partner in the future. If you find yourself feeling down or having issues with the dilator, sometimes it's helpful to say, this is a tool, it's here to help me do X. And whatever your goal is tying it back to that. And that also helps us from a psychological standpoint avoid dissociation. And that's when our body and our mind are not communicating well. And sometimes when there's a history of trauma, our brain can take off and we realize we've not been paying attention. You've had that experience maybe if you're driving and you arrive at your destination and you don't remember quite getting there. It's the same sort of brain wandering. And during the dilation therapy, as Irina so astutely pointed out, we want you to be cognizant and focused on what your tissue and your body is doing to control the muscles. So those are some of the tips that I say and some of the reasoning behind. But yeah, there are so many different dilators, just like there's so many different types of people, and whatever you choose is the right choice for you.
Mm-hmm. Irina, do you have anything you'd like to add?
In regards to materials, I look at what patients already have. Sometimes it's the cost that's an issue. I work in public, but I work in private sector as well. So I know everybody wants the best, so I show them the variety, and then they can sort of choose if they want to buy and purchase. It also matters of what we're trying to achieve. So if there's more webbing, and somebody posted a question, if you've had a hysterectomy, so there's a vaginal vault, which looks like, for those patients who don't know, it's like a sock that's been, closed at the top because the uterus is gone. We might need those more blunted, like the ones that Amanda is selling and showed. But there are those that are a bit more tipped, which can sometimes help a little bit with more that entry at the hallway of the vagina, where there's a bit more of a scarring, because it starts narrow and then you can sort of gradually build in. So it really depends. Again, I keep coming back. It's very individual. I give choices to my patients. I do use in public sector glass because it glides, but it's most importantly, we can sterilize it. So then we can reuse it. That's another thing. So varies. I'm sorry, it's not definitive.
Okay. I can't believe we don't have another question. Maybe we do. Let me look. So if moving forward with this, I'm wondering if we were to come up with something that we want patients to approach their doctors with, I'm realizing when you're in the middle of being diagnosed, as Mary said, being diagnosed with cancer, going through the treatment, for some people, you feel really sick, and the last thing you're thinking about is your vagina. What would be a good, if we were to put together, let's say, patient literature, which we're actually working on, what would be some things that we would want to have on our list of what do we say to our doctor, or what are we, how do we approach this? What are some of the main points that as a patient we can say or do to advocate for ourselves in the very beginning, and later too, but certainly in the beginning would be nice to know.
I think the
Mary.
question we all need to ask our doctors at the start is, what are you going to be doing to look after my vagina?
Perfect. They would probably look at you like you were crazy. I remember my oncologist when the whole thing with estrogen cream, he just like turned green, and it was like, you can't do that. That's causes cancer. It's like, oh dear. Okay, so what are you going to be doing to look after my vagina? Any other? That's a great answer.
And also, I want to be referred to see a pelvic floor physio. Thank you.
Yes, perfect. Other things that anybody, suggestions people have? Irina, if we had a list of maybe 5 things we wanted to make sure we say when we get in there.
I would prompt them to also ask about the vaginal estrogen. I totally agree with Mary. Nothing replaces estrogen if you can have it. I know there's all these moisturizers, but estrogen is what the vaginal tissue loves. So I would have that and raise the concerns you have a really honest and say, this is what I'm worried about. What about this? What about that? So that's also, and also ask, is there someone I can touch base if I get overwhelmed by all of this? Who can I go and see in terms of like counseling or psychology training? So that's really important.
Yeah. So we're coming close to the end. I knew this would happen, even though we didn't, we thought we had a lot of time. I know that what's going to be asked is, when are we doing something like this for men? And that's in the works, but I think we'll probably do a second one of these with Trevor, and I would love some feedback from the speakers as well as the participants in terms of what you would like to have us cover in the next one. I just want to finish up on time because I always promise to do that. But this was lovely, and thank you, Amanda, for showing up, and Mary and Irina, and thank you everybody for coming. I wish this conversation had happened 14 years ago. That would have been nice. I would have loved to have heard it. And I think there's a lot of us who would have. So, Audra, could you give us I'm going to, there's a study, a quality of life study that if you don't know about it, it's on the website, on the IANS website, but it's an opportunity for people who have been diagnosed with anal cancer and have gone through the treatment to share their stories about their quality of life, and certainly our sexuality is part of our quality of life. So the survey continues. So if anybody would like to fill it out, I'd really appreciate it. And it's on Ian's website. We also have a podcast. I think I've pushed that too, but there's a podcast that Ian's sponsors. So if you get a chance to listen to that, and all these are recorded. So if you want to go back and listen to some of the former ones, Mary and Irina have both spoken before, and they're really valuable. So thank you so much for being here, and we'll see you next time.